Welcome to AETCM, the Emergency Medicine Channel. A 46-year-old man came to the ER with alleged history of ingestion of organophosphorus. On initial 10-second assessment, airway was patent, there were no secretions, C-spine was normal. Breathing, air entry was equal both sides, there were creps but no wheeze, and respiratory rate was 20 with a saturation of 99% in room air. Circulation, BP was 180 over 100, heart rate was 98 per minute. Disability, GCS was E4 V3 M6, pupil 3 mm dilated and non-reactive to light. Exposure, temperature was 98.2 degree Fahrenheit and GRBS was
non-reacting to light means there is no reaction.
Fixed, not reactive.
Fixed.
Patient was actually referred from outside hospital. In outside hospital already he had received whole body surface decontamination as well as gastric lavage has been done with charcoal. And he was started on Atropine, like total of 14 milligram of bolus dose of Atropine was given from outside, and he was started on 1.4 milligram infusion. Also they had started on pralidoxim, 2 gram IV was given in NS over 5 to 10 minutes, and he was started on pralidoxim infusion 500 milligram per hour. And
what is the dose of this one? What is it? Stomach wash here given? No?
Sir, outside 50 grams of charcoal
15
they had used. 50. 1 gram per kg.
1 gram per kg. Okay.
They had given from outside.
How do you give normally in emergency room? How do you give this active charcoal in patients with poisoning?
So 1 gram per kg.
How do you give?
Sir, via Riles tube.
Have you ever tried this charcoal through Riles tube? Is it very easy?
No, sir, the broad tube.
It will be sticking and it is very high viscosity, it cannot go away.
It is not like what we are telling. It is very difficult to give it through the this one. For taking in through mouth also it is very difficult. Okay, whatever it is, we have to give. There is no other choice.
So when patient arrived,
what is the action of this drug? Activated charcoal.
Absorption.
Adsorption. Okay, it will prevent from absorbing into the bloodstream.
So sir, when patient arrived,
so can you tell me about the multi-dose activated charcoal? Where will you give multi-dose activated?
Ingestion, amount of large ingestion of poison. Even after 1 hour also we can give. Repeated washes can be given.
So large ingestion you can give. Even after some hours of like when you take large doses of poison, you can give multi-dose. Then other than that, any other condition you can give multi-dose activated charcoal.
Continuous exposure.
Continuous exposure, where will you get? That is correct.
Okay.
Sustained release tablets. If the patient had taken sustained, you know that it is sustained release tablet, then there is a chance of repeated, like you told, sustainedly it can come to the stomach. Okay. In that condition, multi-dose activated charcoal will be very useful. Okay.
Sir, adjuncts to primary survey. Sir, initially when patient came, again we had given a whole body decontamination with thorough washing was done, and following that we had taken a VBG. The pH was 7.45. With
why you are giving whole body wash?
So because it can be still absorbed from the skin. Like, organophosphorus can be.
What are precautions you take?
So we have to wear personal protective equipments ourselves, and then whatever clothes the patient is wearing, all has to be discarded. They have to, like discarded as in like removed, and
but you have to keep it because it's an evidence.
Yes. Okay. So, and then have to send for toxicology samples.
So you should never throw the clothes. That will create problem. If the patient dies, then these all evidences.
So VBG was showing a pH of 7.45 with a PCO2 of 40, bicarbonate of 29.2, potassium of 1.9, creat of 1, and lactate.
What is the reason for this hypokalemia? What do you think?
So patient actually is a known case of stereospose donor renal allograft recipient.
So that means all recipients will have hypokalemia. Do you think it is like that?
He has interstitial nephritis.
Do you think that that has produced this hypokalemia?
He has been hypokalemic. He has been on supplements of spot chloride and potassium tablets for last.
Okay. What might have precipitated this problem now?
Vomiting.
Vomit
As-
secretions,
vomiting, aspiration,
aspiration.
everything will produce hypokalemia.
Then
What is the bicarbonate in this patient?
so 29.2. Metabolic alkalosis was there. Sir, total counts was 16.7 with a CRP of 95. CRP of 95. Sir, chest X-ray as such did not show any abnormality. An ECG
What are the
was
common
normal.
abnormalities seen in OP poisoning, chest X-ray?
Aspiration.
Aspiration. Okay.
So an ECG was normal. Heart
Only
rate of
aspiration,
98.
anything else can happen after some time?
Fibros.
Fibrosis in other poison. Which poison?
Petroleum. Chemical pneumonitis.
Paraquat.
Alveoli.
Here what will happen? See, first day it's only aspiration. Second day onwards there is another problem can occur in the chest X-ray. What is that? ARDS. ARDS is one of the modes of death in OP poisoning, large dose OP poisoning. Okay.
The ECG was normal sinus rhythm. Then, sir, coming to sample history, patient is a 46-year-old man, known case of donor renal allograft recipient in 2020, systemic hypertension, dyslipidemia, seronegative arthritis, small vessel vasculitis, hypothyroidism, and thrombotic microangiopathy. Patient actually was found lying on the road near to his house at around 8:30 a.m. by family members. Bystanders give history of alleged ingestion of insecticide, that is a combination of chlorpyrifos and cypermethrin, syrup, potchlor, and potassium tablets, as the empty bottles were lying nearby him. The history of vomiting, passage of stools and urine was given by the family members. Patient was initially taken to an outside hospital from where gastric lavage and surface decontamination was already done, and he was started on atropine infusion as well as pralidoxime infusion and was referred here for further management.
What is the current protocol of gastric lavage in poisoning?
So within first 1 hour, if patient presents, then we can do gastric lavage along with charcoal.
Can you give after 1 hour?
Can be given, sir, but
Tell me scientifically. Can be given means if you like you can give, if you don't like you can. Tell me scientifically whether it can be given or not.
Dose ingestion after 2 hours.
What is your opinion?
4 hours.
Ideally it is 1 hour. What she told is correct. But in a large dose quantity, when the patient has already taken a large quantity which may not clear by 1 hour, you can still give extended time gastric lavage. But theoretically, it is only 1 hour. Okay.
Then, since patient's CRP was around 95 and total counts were high, and since he was immunocompromised, so we started him on antibiotics. He was started on piperacillin and tazobactam, and patient was like after admission, following that his sensorium started to deteriorate. So patient was
What may be the reason for sensorial deterioration?
Either it could be due to direct organophosphorus
Or
activity,
okay, neurological manifestation.
neurological manifestations, and also it was also going in on atropine infusion was also going on.
So atropine induced toxicity you want to tell. Okay.
After that, sir, injection atropine.
What is the clinical finding of atropine toxicity?
Patient clinical findings of atropine.
Clinical.
The secretions will start disappearing.
Clinical findings in atropine toxicity.
Sir, atropine toxicity patient will be
You
having.
are seeing the. Don't turn.
Tachycardia.
Tachycardia is a feature of atropinization.
Atropinization.
I am asking about toxicity.
So, dry urinary retention.
Urinary retention is a feature of atropine that occurs in elderly individuals. Toxicity means when you are giving large doses, no, patient can have some acute adverse effects. What is that?
Agitation, confusion.
Agitation,
anxiety.
confusion. It is not loss of consciousness. Loss of consciousness occurs due to OP poisoning. But here patient will be more agitated, confused, high degree fever. All these things are features of atropine toxicity. Okay.
Sir, as patients was.
How long
CT
atropine
pain.
will act? If you give an injection atropine, how long it is?
3 minutes.
Okay, that's why we try to give infusion. Infusions are always better than bolus doses, but secretion wise there is no difference. Secretions can be reduced both by your bolus injection and infusion. But heart rate, this one only that atropine induced heart rate will last only for 3 minutes or 4 minutes. Okay.
So the patient was on atropine and pralidoxime, following which patient actually started developing high grades of fever at night with a shooting heart rate of around 150 and temperature was not coming down even after giving paracetamol. It was around 104, 100 degree. Following which tepid sponging was done, cold saline was also given, but still fever was not coming down, following which patient went into an episode of desaturation with bradycardia, following which we had to intubate the patient. Crash intubation was done, and after that patient went into hypotension. We started him on inotropes, but the BP was not picking up. So we had to start him on 3 inotropes, vasopressin, noradrenaline as well as adrenaline were going in full dose. Still patient's BP was not picking up. So sir, we had also given stat dose of steroids, but patient BP
could not survive. So steroids, what is the use of steroids here?
Septic shock if I suspecting
refractory
shock.
Septic shock. Okay.
Septic shock. That's why bolus dose was given, but still patient's BP did not increase. And after around 12 to 18 hours, around 18 hours, the patient was on inotropes. After that, patient.
Tell all the clinical findings seen in OP poisoning.
Sir, organophosphorus poisoning will have cholinergic as well as nicotinic effect. Cholinergic effects would be diarrhea, diaphoresis, urination, meiosis will be there, bradycardia, bronchoria and bronchospasm will be there, emesis will be there, lacrimation and salivation will be there. And then nicotinic side effects, nicotinic effects would be hypertension, mydriasis, tachycardia, there will be weakness, respiratory muscle weakness can be there, hyperglycemia, pain abdomen can be there.
Pulse rate?
Pulse rate. Usually, sir, it can be bradycardia because of cholinergic, but due to nicotinic side effects, it can also present as tachycardia.
Some patients can have tachycardia. Tell the causes for tachycardia in OP poisoning.
So one is nicotinic side effect. One is atropine induced.
Atropine induced.
Third one is co-ingestion with alcohol. There can be.
So these are the common causes. So 20% of the patients can present with tachycardia. What are the toxidromes you see in what is a toxidrome you see in OP poisoning? So whatever you told is that is a toxidrome. Constricted people, bradycardia, increased secretions. When you are giving atropine, what is the end point of atropine? Secretions. Not pulse rate, not temperature. It's only secretions. Now, what is the role of pralidoxime in this?
So pralidoxime actually is useful only before the aging process sets in. So it is useful in reversing the binding of organophosphorus to the enzymatic side of the compound of acetylcholinesterase. So it binds to it and it removes it from the site so that activity of acetylcholinesterase is functional. So only before 28.
Carbamates, can we use it?
No, sir, because carbamates is reversible already.
What are the phases of OP poisoning? Phases.
Acute toxicity, intermediate syndrome, and there's a chronic delayed neuropathy can be there.
What is intermediate syndrome?
So intermediate syndrome develops around after 24 hours to up to 72 hours it can develop. The main feature of this is weakness. Patient will start developing ocular, neck muscle weakness, respiratory muscle paralysis. Patient will have tachypnea.
So almost all features of acute poisoning will be there. How do you treat it? Atropine. Pralidoxime?
24
after 24 hours there is no use in giving it. Atropine is the only treatment. Suppose the patient develops atropine toxicity. What do you do?
So I lower the dose of atropine and start him on glycopyrrolate, 0.6 to 1 milligram per hour.
What is the advantage of glycopyrrolate? What is the disadvantage of glycopyrolate?
So glycopyrrolate will help in reducing the secretions, but it won't cross the blood-brain barrier. So no CNS effects would be there.
So there is no CNS side effects and there is no CNS effects. So suppose patient has got organophosphate induced CNS effect, but he is over atropinized. What do you do?
So you need to continue atropine, but to add glycopyrrolate.
So you reduce the dose of atropine, add glycopyrrolate. If that is not there, you just remove atropine from the regime and start on glycopyrrolate. Okay, that can be given. Okay, what is delayed polyneuropathy?
So delayed polyneuropathy.
Where will you see this type of patients? Is it common in acute poisoning?
So no, after around 20 to 30 days.
It is a long-term process, mainly seen in acute poisoning. It is not very common, but if the patient has taken large doses and your treatment is delayed, then you can see it. What is the clinical finding?
So there will be foot drop.
Foot drop in ICU. If you are seeing foot drop in ICU, that is a sign of peripheral neuropathy. Okay, so critical illness neuropathy, here delayed polyneuropathy of OP poisoning, all you get it. Okay, what is the treatment?
So we can do splinting.
Okay, only splinting is the treatment, and physical therapy or physiotherapy is the treatment of choice. There is no other treatment. Okay, otherwise where will you use this? Where will you see this problem other than acute poisoning? Delayed polyneuropathy is commonly seen in which type of patients? It's seen in farmers. Okay, they are chronically exposed to this poison. That may not be a feature of acute poisoning. Okay, acute poisoning, it can happen only if the patient had taken large doses and your treatment is delayed. Then you can see all these things. You can see foot drop in your ICU. Okay, what happened to this patient died? You want to tell anything else about OP poisoning? Have you read anything more than what we discussed? A lot of things are written. You want to add something? No. Huh?
According to the ophthalmologist, in retina we can see optic atrophy, long-term.
Long-term use.
They can be on the macula, there can be geographical atrophy, and there can be geographical patches seen, which is an initiation of any maculopathy. Initially, there will be pinpoint pupil, which is a feature of OP poisoning. As the atropinization starts, the sluggish reaction will be still persisting, but pupils will be dilating. We take the endpoint of atropinization as a dilated pupil, and as acute cases or intermediate, as she told, there won't be any geographical atrophy, anything seen. Visual acuity can be decreased because of blurring of atropinization can be the only thing. In chronic cases, geographical atrophy can be seen on macula.
So in routine clinical practice, atropinization means dilatation of pupil. But in OP poisoning, atropinization means secretions are reduced. Total reduction in the secretion. Do we catheterize patients who are admitted in ICU for
before starting?
Preferably before starting atropine, you have to catheterize the patient. Otherwise, patient develop definitely urinary retention. Okay, these are things you have to take care in ICU. Okay, thank you.